allergy interaction checking, pharmacy benefit eligibility checking, formulary compliance, a medication history reporting, followed by prescription routing to a retail pharmacy or a mail order pharmacy. So those are the inherent functions that will be the part of the research efforts. Current knowledge, we have some excellent studies on personal health records, cost-benefit analysis of VISTA, the VA system, a return on investment of telehealth systems, return on investment for CPOE or computerized physician order entry, even the costs of interconnecting health information exchanges. But by and large, many times policymakers have to rely on estimates that are based on expert opinion rather than evidence. And in some of the, we're going to talk about Delphi studies in a minute, but in some of the Delphi studies, the earlier ones, policymakers in Latin America and various other places will rely on expert opinion to make certain decisions. And so where there isn't evidence, you can't do, for certain of these things, randomized clinical trials. So, example, you can't do a randomized blind clinical trial on using EPIC versus Cerner. And that was noted in a recent piece of literature, which I think I'll add to my dissertation documents. But so it really is a lot of expert opinion involved in this. One question I always have is who are the experts, and we'll get to that. Much of the related research doesn't identify all the stakeholders. Noted I said earlier that most of the costs are borne by the clinicians currently, and most of the benefits are inure to the payers. Well, obviously the vendors are stakeholders. The vendors have weighed in pretty large on some of the issues we have with health IT and meaningful use. Other stakeholders include, pharmacy benefit managers and the equivalent group in the UK, and society as a whole. And I think when we say payors, it could mean a government payer or a commercial payer alike. Some of the current research tries to address return on investment in the context of a specific setting, medical group or hospital. But having a pretty strong finance and accounting background, I can tell you that this is not really transportable anywhere. And it really is just one specific medical group and one specific thing, because what someone pays to purchase a particular technology and the update and maintenance could vary based upon a number of things. Also in e-prescribing, we have the notion that sometimes it's part of a module of computerized physician order entry. So the knowledge base and the unmet need, without additional research, I think it's difficult for payers, integrated delivery systems, legislators, and those who influence public policy to make rational decisions about the use of certain health information technologies. And how to go about determining how to set and align incentives. And why is this important today? Well, as the system moves from payment for fee-for-service to payment for quality and cost-effectiveness, a lot of the systems are changing. And in the context of those changing systems, a lot of the payment mechanisms are being revised. For example, in an ACO or a CCO here in Oregon, you might be incentivizing certain clinicians to manage a diabetic patient, a COPD patient alike, and the use of informatics tools in that could be important, and often is. The long-term goal here is a set of framework that will assist in the development of these incentives and payment mechanisms in the context of health IT, and focus on these applicable quality, benefit, cost, financial considerations. And the reason is that you can spot this in some of the literature, even the scientific literature. It is critical to align risk and reward for health IT investment. And it's one of the problems with meaningful use, in the sense that it's not paying for everything. It's not aligning all the risk and reward. It's just a payment for having the technology that does this. And going forward, if it's going to be actually used in the context of increasing the quality of care, there needs to be incentives for doing that, and both on the time of process and outcomes measures. So e-prescribing, how does it work? The clinician is essentially the client. The client signs into the e-prescribing system by communicating with the server. And the system is typically e-prescribing software, or as I noted a bit earlier, it could be a module of a CPOE system. The sign-on process maintains the security of the system. the clinician would need to prove his or her identity and verify legal prescribing permission. And whether I look at those systems in the United States and the UK, it's just different, but there's a similarity to actually how they go about doing that. The clinician inputs the patient's name, reviews the current data about the patient, including current and past medication. Clinician selects the medication to be prescribed, and the clinician signs the prescription and transmits it. Now, in some places, for example, in the UK, this would happen if the patient mentioned a pharmacy, but if the patient didn't, they would get a script with a barcode. And even though they don't have the same thing as pharmacy benefit managers in the same way in the UK, they sort of have a similar system where a group decides what the equivalent of the amount that patient might pay. It might not be called a copay or deductible, as it is here, but actually there it may be based on age and how much your coverage is. So it's a very similar system. The clinician's signature is a digital signature. It's verified through public key cryptography. Digital signatures are made with a private key, and the verification is with a public key. And this seems to be similar throughout the systems that I've studied throughout the world. Then there's this notion of RX Hub. And RX Hub is really a facilitator in this process. And so the e-prescribing system connects with RX Hub, and you'll see up top there it talks about the PBMs, pharmacy benefit managers, or health plans. So many of the health plans contract with PBMs or have PBMs, but this determines whether the patient's eligible for a particular payer and the patient's co-payment or deductible. So the important part there is that the physician doesn't have to make, or his office, an oral query about a particular thing. And this could deal with what tier of the formulary the drug's on, how high the copay is, or whether it's covered or not, or whether you have to do something else to get off formulary. And then this can be presented, meaning the formulary applicable to the patient, and their medication history presented to the provider at point of care, and the patient's preferred pharmacy can be verified. So in real life, going to my particular clinician, who the only thing he has that's electronic is e-prescribing, as a paper records right outside when you walk in his office, you can see how simply he does it, and he asks you, what pharmacy do you want? And if you tell him, then it appears, assuming you have gotten to the point where they figured you're eligible and the like at your pharmacy, your script. So the communication's accomplished through transmission control protocol, internet protocol, and the data is encrypted. And in the United States, if Medicare Part D is involved, and a user wants to qualify for meaningful use, she has to use the National Council for Prescription Drug Programs script standard, with one exception. If it's a situation where they're all part of one legal entity, the pharmacy and the providers, then they can use HL7. The specific aims for my work are to identify what models are presently applicable in the area of health IT, particularly e-prescribing, which identifies stakeholders, quality, benefits, costs, and financial effects, and they're all over the board. To develop a way to identify the most important quality, benefit, costs, and financial effects, and to prioritize them, because I think it's important when legislators or payers look at these types of things, what do the stakeholders think are more important to them about these particular categories? To provide an expression of what I learned about quality, benefit, cost, and financial effects in a framework. And then here's an example. It's very hard finding an example of e-prescribing that you can kind of get your hands around. I'm not saying I get my hands around this, but the best one I found was from the UK. And see this thing called a PPA? That's the Prescription Pricing Authority. That's similar to our PBMs. So that processes the payment for the prescriptions. So the GP sees the patient, and he or she, the patient either says, yes, I want ABC pharmacy or not. So it's very similar in many respects to the United States system. So this goes through the store here, that's considered our pharmacy. So, or pharmacy. So what happens essentially is electronically the GP would prescribe something, the PPA, the Prescription Pricing Authority, processes payment and determines eligibility and the like, and what the copay might be. The pharmacy gets the electronic thing, and the pharmacist can be in the pharmacy. So this just shows how the pharmacist looks at this, determines, goes through the drug allergy things and the like, and how that's going to work. And then essentially the patient either gets a script, in this case, with a barcode, if he or she hasn't mentioned the store, the pharmacy they want to go to, or it just appears at the store once this happens. And in the UK, there aren't a lot of the same coverage issues. It's more based upon age and whether you're covered, but that's a simplified version, the Salford model. So the research question here is for implementing health information technologies such as informatics technologies like e-prescribing. Can we identify the applicable stakeholders and the attendant quality, benefit, costs, and financial effects? And can we prioritize these latter? So we can have a framework that can be used by payers, integrated delivery systems, and legislators that will assist them in the development of these payment mechanisms and incentives. And so why this is timely is because, as I mentioned earlier, a lot of these payment mechanisms are evolving under payment for quality and cost effectiveness. So in that regard, I've selected the Delphi method as a way to answer the research question. So you'll see in the upper right corner 3 Delphi oracles. This is, and you'll see below that, the RAND Corporation in Santa Monica. I've been to the RAND Corporation. It's quite an impressive place. This originated in a series of studies that the RAND Corporation conducted in the 50s. I've read probably 50 or 60 Delphi studies and RAND studies. It's incredibly interesting. But it's a technique to obtain the most reliable consensus of a group of experts. And if ever there was a project to apply the Delphi method, it's this one. Because as you look at the current research, is literally all over the board. There's no standard framework or model. It allows a group of experts to address a complex problem. You get feedback from the individual contributions of information and knowledge, and it's done with a series of questionnaires in generally 2 or more rounds. My friends at Wikipedia, which we're not supposed to cite, so it's not on my slide deck, said it's been used as a tool to implement multi-stakeholder approaches for participatory policy making in developing countries. So you can see when, and we probably should use it in the United States because many of our policy making doesn't seem to be based on any evidence either, but at least this makes some decisions on a major scale in countries based upon what some experts see. And there's been all sorts of studies in 40s and 50s about making bombs and the various things through the RAND Corporation technique. Anyway, it's a form of controlled feedback. There's no direct confrontation of experts, and it's anonymous. So everybody, when they're going through the process, will know who the other people are, and oftentimes they don't know who they are at the end of the research. This seems like this really wouldn't work for a PhD dissertation where you think you have 30 experts around the world and you don't mention who they are. So we'll probably work on that, but mention that later. So here's an application of the Delphi method outside of healthcare. In the mid-'80s, a survey was made of chief information systems managers of what they thought the most critical information management systems issues were and a consensus of their importance. The data was collected in 3 rounds of surveys, and they ranked ordered the top 10 issues. So I don't know whether we'll be limiting it to 10 issues for each stakeholder in terms of quality, benefit, cost, et cetera, but the idea is trying to rank order them in some form. What do they view most important? Now, one of the reasons for this, of course, would be if you're setting a payment mechanism or an incentive system, it's helpful to know what a particular stakeholder that might be incentivized is going to think is most important to them. Because many times things don't always have to be financial, although they have financial repercussions. And so it may be that in a particular country or state or ACO model may be different, but knowing what a panel of experts think is most important will be helpful in that regard. And this lends itself later to a ton of potential qualitative research, as you can see, in the sense that what do they think in Pennsylvania about this, some market or whatever, compared to somewhere else. An example of an application of the Delphi method in healthcare. This I thought was kind of interesting because there was a research project working on cost-benefit analysis of EHR by primary care physicians in an ambulatory setting. And so what did they do when they couldn't find data on cost and benefit? They used a modified Delphi technique. All right, so they came up with a consensus. Here's only a 7-member expert panel. And basically they're guessing that adverse drug events would be reduced by approximately 34%, so a range of 10 to 70%. And alternative drug suggestion reminders would say 15%, ranging from 5 to 25%. So they didn't have, so you can just think about this. We're at the stage where you can't even do, it's a great study, but you can't do a true cost-benefit analysis without having Delphi experts guesstimate the number of adverse drug events and percentages and alternate drug suggestion reminders. This is not going to be terribly persuasive to many government people, legislators, and health plans. So I think that the idea of having, in this case, we're talking about 30, and looking at different systems is probably more robust. But this happens oftentimes because the data is not available. So when people say, we don't think EHRs pan out or whatever it is, and the like, many times there are guesstimates involved in what happens. So what are the methods? Well, still continuing literature and internet search to identify existing models, research what are the most important quality, benefit, and cost financial considerations. So I can start with an idea of what they are for the Delphi experts. Preliminarily, I've mentioned here patients, providers, but if you're being global, it's probably going to be providers / prescribers. They're going to have a different sense of someone who can't prescribe. Payers are also going to be governmental entities, ACOs, CCOs, and the like, depending upon the country and the market. And the pharmacy and a lot of the UK research, they refer to them as the dispensers. So I certainly have to spend a little more time figuring out, is it 3 or 4 things to put as what this entity is, because I don't want the folks, if there were folks in Ireland, to not. And then I guess pharmacia, the whole 9 yards. Pharmacy benefit manager, as I said earlier, these are the prescription pricing authorities, at least that's the similar thing in the UK. And then the possibility of including vendors. Second method, part of the methods, is enlisting a panel of global experts who could be stakeholders, researchers, noted authorities, and others, and present them with the results of the initial research and certain questions in what we'll call an online survey or questionnaire. And I'm kind of trying to figure out REDCap now with the OHSU folks, which will help facilitate the identifying additional stakeholders, prioritizing the quality, benefits, cost-effective financial effects of health IT, particularly informatics, technologies, e-prescribing. The idea here being that some of the Delphi methods use 4 different panels of experts, depending upon who they are, what their background is. It seems to me that if you're a physician, take Dr. Hurst, for example, an educator, a researcher, and potentially a patient, you fit in a lot of the boxes. Okay, so I can't just say, all right, well, I just want academics on one panel, clinicians on another panel, or politicians on some panel. You could take some of the politicians that are physicians. So the idea is that instead of having 4 different tracks of people, to have approximately 30 that may be of all ilks. Maybe some would be patient advocates, but there are a number of professors who are patient advocates. Asking the experts to prioritize the quality, benefits, and cost of financial effects from the perspective of the individual stakeholder. So if they're looking at the stakeholder being a patient, the expert would look from their perspective as a patient, what were the most important things to them, rather than their perspective from a clinician. summarize the answers to the questions of the first two rounds and generate new questions based on the summary. This is just a possible idea. It could be a whole poster board of what it might look like. But the idea would be you could see most of the result of the research probably in one big poster board if you put it there. So it would be generating a framework which should facilitate the use of future informatics tools. So you can see you can do this for any informatics tool in the transition from fee-for-service to payment for quality, because the payors, integrated delivery systems, legislatures, and people who influence public policy then have a model which would assist them in these incentives and payment mechanisms. Here, after we go through 3 rounds with the preliminary framework, the idea would be to forward it to another but smaller group of Delphi experts to ask them how useful they think the framework might be. So you could see that these people that are in this group of Delphi experts could be more slanted to be payers, integrated delivery systems, legislators, clinicians, and the like, the types of people that would make those decisions on you today. So what is the significance? Payor, integrated delivery system, legislator, the like, they can choose any number of stakeholders to look at as they're designing a system. They can look at certain quality benefit type things, cost adverse effects. They can include them or not include them if they think they're important in their system. They can use their estimates. They can use other estimates of what they think quantitatively the component is. They can decide that they want to do a return on investment. So the last column here might be a formula without numbers in it, but people to come up with what they think the return on investment might be for their particular situation. So how are they going to allocate the money? The end result is to make better decisions with respect to these emerging payment systems than ones that are now based upon, in my mind, guesses, hopeful expectations that it will work, etc. So what are the limitations? We only have one health IT informatics technology we're using, E-Prescribing. And I can tell you that's difficult enough trying to put the parameters around this. And there are over 600 E-Prescribing technologies that are part of ShareScripts. So, and you go to those websites, and some are gone. Some have been bought. The healthcare industry, people buy and sell things all the time. So just trying to get your handle on one form of the technology is difficult enough. And we'll only have a response from a limited number of global experts. Although much of the research I've seen said 12 to 14 global experts is enough, so we're going to be more careful and try to have around 30. And as you can see, the research is in its infancy. I'm glad that this research is starting in the West, because it really is the Wild West in this area. There isn't really that much there that's it's important, but it's not as useful as it could arguably be. So the timeline, I'm here today. Defense of proposal, June 13th. I'm hoping to work with Joan to figure out the IRB submission for this and do it this summer. Having reviewed a lot of IRB issues in the past, as a lawyer, I can tell you that it's much more difficult when you're submitting one rather than you're just talking about the ethical issues of a particular project. The first round questionnaire, hopefully that would be this September. It would be this would be like, in a Delphi world, this is called brainstorming. So I'm going to come up with what I think some of the stakeholders should be. I'm not going to rank order various benefits and quality, but give them some ideas. I will probably, for purposes of make it better, I might, if I have 10, for example, quality considerations for a provider, I wouldn't start with the same one for every each of the 30 Delphi experts. I might start in the middle of one so to mix it up some. And so I'd ask them to put whatever additional stakeholders they wanted and to set their own priorities. Then in round 2, which I would anticipate November 2014, this is what is known in the Delphi world as true narrowing. So you ask them to, I summarize the result of the first questionnaire. You ask the Delphi experts to reconsider their prioritization of the various components from the benefit of each stakeholder. And so you try to get them to narrow down what they think. And of course, at this round, they will now seen stakeholders potentially they wouldn't have seen, and quality or cost benefits they wouldn't have seen based upon, hopefully, the results of others. Then we go to round 3, anticipate January 2015. We'll be summarizing the results of the second questionnaire, noting for the Delphi experts that this is their last chance to reach a consensus, and for them to reconsider their prioritization. And this is why the anonymity is important. So if I said in the questionnaire, noted who had said what, and since Blackford Middleton on my committee is one of the leading authorities in the world on some of this issues, and I say he ranked this, this, and this, that could affect what somebody else thought. So the idea is that they'll see that maybe, in this case, 17 out of 30 people thought this would be rank ordered 1, but they want to know who those people are, and would that then change theirs? So the last part of this aspect of the Delphi study can be known as, doesn't always have to be, but known as the statistical group response. So that this study may be finished in round 3, and there may not be anything that you can get meaningful from a statistical standpoint, and we may be done with that, and we may put in a framework and then move forward. On the other hand, there's a possibility of looking at whether the mean ratings of the top issues are significantly different from one another. Could be a Bonferroni. There's a possibility of looking at cap inter-rater things with who graded what way. And the beautiful thing about a study like this is you don't decide that in advance. You wait until you see what the data is. You're just open to the way you might be able to analyze it. So we come up from this with a draft framework. This would be circulated to the new Delphi experts. I'm hoping that would be March 2015. And there'd be a determination by the new Delphi experts of whether the framework might be useful and how useful for payers, integrated delivery systems, legislators, and those who influence public policy in developing these payment mechanisms and setting and aligning incentives for various stakeholders. So then I would propose to summarize the right research and pen the dissertation between April and May of 2015 and defend the dissertation in June 2015, 1 year from today, or this month. So with that, I'd like to acknowledge my committee, Dr. Ash, who's been my advisor, mentor, and has given me incredible ideas. Dr. Fletcher, who has certainly added an interesting dimension from a computer science aspect, helping me to understand better the technical aspects of this. Dr. Hunsaker, who his dimension has been incredibly helpful in challenging me to better understand the usefulness of this, how it fit in, and including some of the courses in his group. And Dr. Middleton, who is one of the leading authorities in this area that, off the top of his head sends me 3 articles, or 4 articles. I had a number of the articles, but I didn't catch the exact point until he told me where it was in the article, and then it really created some great focus. DMICE, of course, Jim's group, the Division of Management. A lot of the courses that I have privileged to take in that group have added to my knowledge base. The National Library of Medicine, of course, for my funding. And my law firm for letting me print thousands of documents. Because I look at things well on the screen, and I do mean thousands of pages of documents, and providing a place where I can do this stuff late at night where the lights are on. With that, I'd be happy to take any questions since it's 11:39.
Yeah. 2 questions. Actually, one's really more a comment, and it's kind of a semantic point. When you talk about the purpose, you talk the purpose. The first purpose you give is to identify and prioritize ... And then your sub-purpose is to develop and evaluate a framework. I actually think really your purpose is that sub-purpose, and that what you really want to do is to develop and evaluate a framework. And that's actually, in fact, I was a little worried as you were starting to talk that you were going to focus more, because one of the contributions of a PhD dissertation is new methods and techniques, as opposed to just having a finding. So I think it's important to kind of play up the model part of it. My question then gets to the model. I don't have a real sense for what this model is going to look like. I mean, maybe one thing you could have done was sort of, not that you can predict what's going to come out of your process, but to put up a slide that would have an example. Is this a quantitative model that, like, policymakers will be able to plug things into the parameters and kind of come up with their own evaluation, or is it more of a kind of conceptual model with boxes and arrows and things like that?
It's a model, won't be any arrows, but it's a model where somebody would see the perception of the experts, who all the stakeholders might be, and then under, say, quality benefit, they would have a rank order of what the experts thought the top quality and benefits were. And then similarly, with respect to either financial effects or cost. Now, here's an example, and I don't want to mention the authors, but somebody's made a stab at this in a much different way. List of potential ER implementation and ongoing expenses. And this is it's a 8.5 by 14 set of, there's probably 40 pages here. And they list each expense in a category, and they've taken the time to, in my view, unfortunately, figure out what every cost center in a hospital might affect it. And this made me think that, and I didn't say this right, is I don't really want to do a project. There's going to be a definition around what you can call a quality or cost benefit. So a benefit can be, it simplifies a process, but a benefit can't be, I'll get reimbursed more in the United States system, because that has nothing to do with quality. Okay, so this thing here goes through all these cost centers and how you can capture the expense to get paid in some model. And to me, that's a reimbursement system. And I want to get away from a reimbursement system, and I want to get to a system where some, like let's say you're an ACO or a CCO, you can look at this and say, all right, these stakeholders are benefiting in this order. I'm going to set a new model because there's a lot of new models on the drawing board now. And how can I best incentivize some of these people? What is most meaningful to them? For example, and I took this out, but I had a consumer health informatics example. So a lot of people think today that we ought to be, in a patient-centered world, incentivizing patients to have and use certain informatics tools on a phone, okay? So we have issues like, and this would only tangentially relate this, but under some models and some of the legal systems, which is why I think my background is helpful, you can't necessarily just give somebody a cell phone if it acts as a cell phone. You can give them because it can be an inducement for them being part choosing your delivery system. But on the other hand, you could give them a cell phone that only interacted with their healthcare. Now, of course, with usage much, all right? Those are the types of things, if somebody said, I want to have a robust system of incentives over, and this is not for this project, but you can see where this is going. So how can you incentivize patients to better manage their health and in that process? And this would be across the board. So the framework itself, somebody could say, okay, we're going to go ahead.
So you're going to, I mean, I understand that, and, I know that, in the cost effectiveness world and literature that, people are, encouraged, well, you have to identify the perspective that you're taking, and people are typically encouraged to sort of take the societal perspective. But I guess is this going to be a model that, say, a policy person can, there's a bunch of parameters in the model, and they can plug in things, and then I guess my question would be, would a possible, I know you can't do everything in a dissertation, but would a possible aspect of this work being to somehow validate whatever kind of financial model or whatever kind
well,
of...
the initial valid, that's why we have the smaller group of Delphi experts at the end. So they can say they think this tool will be useful. Where this eventually goes, my understanding was that if you pick a dissertation topic, you should pick one where there's tons of potential research going forward. Okay, so in this particular situation, I can see, and also I have not been blind to the many presentations around here about how hard it is to get funding. Okay, and I don't have those same problems. Okay, so I see a situation where I go to one of the foundations that as a health plan was a spin-off of a health plan or something. They're trying to look at what these models are anyway and what they can do. So I might take exactly what you said, all right, and maybe they might say, given their parameters and what they're doing and their patient population, what sort of priority incentives should they develop given the analytics of what they have? That'd be a different research project.
I mean, on the other hand, you may... those organizations may be more interested, like in whatever grants, whether it's an NIH grant or a foundation grant, it's always good to have as much preliminary work as you can. So I don't know, I'm just saying, giving some thought to, whether your dissertation would have some examples of this applied so that future people funding your research, it would also be a better dissertation product, would have some component of trying to somehow, I know you could never completely validate it, but in all facets, but
oh, I think that'd be fantastic if it was possible. I just don't know how it's possible. I would go into, say, Regents or Cambia and say, even though I know the president, and I'd say, and he's a friend of mine, and I'd say, well, Mark, I'd like to test this out on you. Okay, but that would mean they would have to help design a system based on this. And he'd probably say, well, I'm paying people hundreds of millions of dollars to do various other things. But they might take it and look at it. I'm sure they would at some point. And as they start to recalibrate or look at something, decide it then. But I don't know how I could actually beta test something like that. I mean, I'd love to do it. In fact, I could see a situation where you might go in, qualitative research project initially, to go into a group, and a lot of times they're coming up with new products, or they're looking at different, I could see a pilot project under the CMS Innovation Group saying, let's look at this particular set of issues and see whether these incentives are going to work better or not. And then put that in a particular thing, partnering with some group for a pilot. That'd be fantastic.
Or I won't dwell on this, but maybe there are some papers that have been published that have this kind of data that you could just put in. I'll just leave it at I think it would be nice if this is going to be a quantitative model. It would be nice if there were some sort of at least pilot investigation of the quantitative robustness of it.
Well, remember that one study that I mentioned that they had to go back to Delphi experts. So if you could find it, you would be taking guesses on guesses and adding them to guesses. But we can visit. I'm open to it. I like the idea. I just don't see first of all, there's a difficult enough time that payers and others are having the transition from fee for service to paying for quality and cost effectiveness to begin with. I mean, before I came over here, I was talking to somebody in Illinois about a specific model that involved this kind of stuff, okay? But they're way back here. They want to get here, okay? I think the health plan will work with them. But those are excellent comments, though, Bill. Maybe we should sit down. I'd love to be able to do that. I haven't. That's why I found some of these Delphi methods in other studies, because I don't want to project something I don't want to guess, have the experts guess on guesses, is what I'm saying. But any other thoughts? Joan?
Just to follow up on that, maybe you could use your second Delphi expert group to give you some examples that you could then pursue, if you had time, or pursue after.
I'm sure we'll be talking about all of this, so absolutely. And I've got a lot of good ideas from you, Jim, and Justin and Blackbird, so absolutely. I mean, this is new to me, so I mean, the better we make it.
But my main question was, you've been a bit negative about expert opinion and guesstimates and things like that. How is the Delphi method better? How is what you're doing better than what's been done in the past?
Well, no one's done this exact thing. And in some of the studies, they had 7 experts. I think there's a point at which you don't need any more experts, so I don't think you need 100 experts. But I think 25 or 30 is better than 7. I think that having global experts is also better because it's not just one healthcare system. Because as I go around the world, and I know Bill does this also, a lot of the issues are the same. I mean, the reimbursement systems might be a little different, but people are always looking at whether they think the value of some of these informatics tools outweigh the costs. It doesn't appear that we can take the same approach that the banking industry did, although I think it would make more sense. They didn't do an ROI, from what I understand, on ATMs. They just decided that somebody developed this. This looked like it was the best thing since sliced bread, and people would demand it, and it would make sense, and it'd be more cost effective in their view. Okay, they didn't know, and there are millions of ATMs. So I think over time, people will think that informatics technologies, they'll look back and go, I can't believe we even guessed what they are, but we see this all the time. I mean, you're on the same list as Bill, where people are questioning. You saw the one today, the picture of the toilet. I don't know if you looked at it, but no, I mean that, like comparing,
I thought it was a bidet.
Huh? Anyway, I literally looked at this twice. I saw this on my cell phone yesterday. I go, they're
so. Is that the implementation?
Yes, yeah.
I actually get that in a digest. And
okay.
I don't look at individual messages because I don't have time to read Ross Koppel's and Scott Silverstein's rants.
It generally is those two. But my point is this, that there's a whole set of discussion about paper records. Okay, so I think that discussion can end up being in a number of areas. And so I think people are going to view E-Prescribing because of the handwriting, issues and it being more ubiquitous, and they're going to view that as a better framework for some other model that's dropped into it in the future. Dion, do you have a question?
Kind of a question, more of a comment. I'm looking at what you have on the board for the framework.
Mm-hmm.
And it reminds me a lot of the balanced scorecard type of framework. That you're going towards that type of model. And when they developed that, they actually did kind of a Delphi process, but then they brought like 5 or 6 enthusiastic people that were interested, and they put them in a room in San Jose for 3 days. And that's where the balanced scorecard came from, was that 3-day effort. Have you considered, rather than doing a verbal, just go to Davos and have all the experts come there?
Manuka.
Well, that's what I was thinking, is Manuka.
My house in Wyoming only has 4 bedrooms, so I can't have all of them come.
Manuka is quite reasonable. It's a conference you can talk to Joan about. That's where a lot of Joan's great ideas have percolated and gotten support.
Well, people can get funding to go to these people are going to be from all over the world, whoever
You might just take a small group. I know that there's a funding issue, but you might try and get a group to work through it, and then it's not just you, it's a group of people.
Okay, that's a good idea. I can visit with John. I think that I'm trying to make sure as best as possible this thing isn't United States centric, because I just don't think we have it right here, the whole thing. And I think so if my group was international, okay, I think it lends itself to much. That's why I painstakingly went through the UK system and tried to match up what a pharmacy benefit. Now, it actually was because Justin forced me to do something else, that if he hadn't forced me to do it, I wouldn't have gotten to this other point. So that was good for that. But I think that's a great idea. I'll talk to Joan about it. I do think, though,
Just throwing out something.
I don't want I think the credibility of this is much greater if it's not a bunch of people just from the United States.
Right.
Okay, because I know I've got to figure out a way to tell them, don't tell me a benefit is more reimbursement. So if I hear that one more time, having been in this industry for 35 years, about how we're maximizing, that's great. But all that does is increase the percentage of the gross national product of healthcare. And we're in a current situation where, if you've been following some of these, a friend of mine spent $100,000 a year under Obamacare on drugs and because of the way the exchange is. And I personally think that everybody should have access to quality health care. And we don't have that now. So if we don't this is a chance, at least in my view, this is a chance for us to transform a system based upon payment mechanisms when we are working through that. And I think that the NLM is spending a ton of money for me to try to do something. And if I could make a framework or a basis for people to think about this, so sometimes they're just thinking about this on the fly. I got something the other day. It's from a health plan. It was a page torn out of their book about how they're going to look at this set of models I can't go through. Well, the thought they've had in this is not great. Okay, so even if they don't think this much about this, at least having this to look at this and to think about this, I think would be helpful. Any other questions?
The other comment I could ask you is, do you have your question already?
Oh, not yet.
Okay, I'm sorry. I'm not trying to. Okay.
No. I mean,
have you thought about trying to do a pre-test of the questionnaire before you send it to the IRB? And the reason I'm suggesting that is just because the IRB approves it, and if you change it, you've got to send it back to the IRB, and that could miss the time frame.
Well, I think that isn't necessary here for the following reason. One, I'm going to. It's a good thought. I think that I'm asking people that are the Delphi experts to come up with additional stakeholders. The one way I'd pre-test it would be to send it to Delphi experts anyway and have them give me more stakeholders. Okay. So I think that this is part of, at least in Delphi, what they call the brainstorming exercise. And so I think that is part of the research, the brainstorming exercise. Any other thoughts? Jim?
I got a couple of questions, but since I'm sort of stuck on one question, I'll ask it again. So I'm looking at your slide 25. Don't go back. Just keep it on this one though. And that's the research question, which says that can the applicable stakeholders be identified, the intended quality, benefit, cost, and financial issues be identified and prioritized to create a framework that can be used by a bunch of people to influence public policy that will assist them in the development of payment mechanisms and incentives. So this kind of appears to be a framework. So if I'm Mark Gans at Cambia, how am I going to use this to determine how I'm going to either incentivize docs to use this technology, or how I'm going to compensate them? What's the practical step that happens after you've developed this framework?
All right, so let's take e-prescribing, because that's what we're talking about. Yeah. But you could take anything they think like that PDA, or the digital device with patient information on. So they decide that they want to do a better job of aligning incentives in a system. And they decide that one of the things that's important in their view is e-prescribing, because it'll do these various things. So in looking at how they pay today, most of the time it's a fee-for-service model. They have some more developed models. They might look and say, all right, maybe the patient is incentivized to go to a provider that has e-prescribing. So maybe their copayment is lower if that's the case on their drugs. Maybe they're looking at the provider, and maybe the nature of the provider, maybe over time you have to be a provider that has e-prescribing, because they've looked at the benefits and their this great. Looking at the costs, they may say, well, the costs are too high for some providers based upon this allocation of costs. Maybe we as a health plan should do something to defray the cost in a particular informatics. Any number of things like that.
Does this framework get reduced to an algorithm, or is it a set of questions that the payer looks at and tries in some, I can't imagine that this is totally deterministic, in some way to come up with what works from a business?
I think a payer could develop their own algorithm from this, given their specific types of providers and data and their patient population if they wanted to. That's possible. But this would not be the algorithm itself. Actually, I thought about that.
So then a little more philosophical question. So Michael Porter, in his recent writings on healthcare, is advocating that the true metric is value, and he defines value as outcomes that matter to the patient. The ratio of outcomes that matter to the patient to the cost of whatever it is you're doing. In other words, he's saying that the central point of value is the patient-centric part of it. So how does that factor in here?
I think it's spot on that. So if looking at, in this case, the patient is on the first line.
Now,
So what is important to the patient? The Delphi experts are supposed to be putting themselves in the position of the patient and thinking what?
Are any of those people patients? I guess we're all patients.
Well, that's exactly the point. All right. Now, as somebody said in some recent literature, we either are patients or we will be patients sometime. And somebody then said, well, if you get killed by a bomb or something, you may skip the patient thing. But most people will be patients. And most people have been patients at some point in time. So the Delphi experts would look at, in Porter's example, what are the types of things that they think, putting themselves in the position of a patient, are most valuable to them. All right? They would also look at what the cost associated with that patient would be, or the cost. It's not about putting in a specific number, because the other research shows the numbers are all across the board. So that works well in looking at my example of the PDA. So if you were going to, and if somebody felt that I want to be able to access my information about my pharmaceuticals that I take or drug interactions or my lab tests, this may be one of the greatest things of value to a particular patient. It may be the ability to easily access something from a phone. If that's the case, then what are the costs associated with making that informatics technology available to that patient? This sets a framework for looking at what those issues. So it's spot on, fits right in. I think it's a great example.
Yeah, I understand all that. I think that value to the patient is not necessarily the same as value to the payer, and if we want to ensure that value to the patient is what wins in the long run. I don't know. Maybe that's out of scope here, but
I like the idea. First of all, most health plans, if we're talking about a commercial health plan, are in the business of selling policies.
And making money.
And making money, absolutely.
For shareholders. If they're for profit.
Yeah, and the other ones, I don't know why they're making money for, I guess, but anyway.
Pay people like your friend big salaries.
Right, okay. But, so I won't comment on
Which is more than $1 million
I won't
a year.
comment on Diane Lem's report. But, so here, though, this is important because if you're a health plan, your goal may well be to maximize, your value may be different and it may be more monetary but still quality so you don't get sued. But if you're looking at how you're going to do that, this is why I think the informatics world and patient-centered world fits right in with that. You're going to have to, one, work toward keeping the cost of a specific patient down, the care for that patient. If that patient, some research has shown that if some of these learning tools, if they're done as a game for a patient, they watch it more and they learn more things. So it may be that you have an informatics tool developed as part of a game. Now, it's not necessarily because the health plan feels it wants to be magnanimous about this. It's going to be because the health plan feels that because this has a specific value to a patient, and the patient may use it more in the benefit of their care, it may keep our costs down as a health plan. So while we might be in it to make money, it may well be we'll make more money if the patient keeps their diabetic situation in control more because we provided them informatics tools to help do that. So, and I think this is exactly what you get from this kind of framework. It makes somebody think about that you can align. The whole idea that the alignment of incentives is that if a health plan idea is to make money and a patient wants to be better, how can you align the incentives in a monetary perspective with informatics tools to make that happen? Any other thoughts? Questions? Dean?
Okay, just one thing I'd say is review the ERB filing stuff before you get too far down, because one of the things they do ask about is if you're doing something that involves patient values, are you including the underrepresented minorities in the process? That's a question. You know, how do you make sure you're filling a cross section? So watch how you define your stuff.
I see that in terms of this technology because of the digital divide.
But are you involving them in your study? Are you going to have them as people that are responding to your experts panel? If not, and if you're supposed to be representing patients, shareholders, why not? Stakeholders, why not?
So maybe I should have something that, when we address the experts, that includes something like, don't forget these types of things. Because I can't have a...
or give me patient data.
I don't know why I keep patient data, but okay, I get the
that he
idea.
necessarily represents.
I
know, but I'm just saying, but
I think he
you see what I'm
represents somebody
saying?
on the speaking trail. Yeah. But anyway, but that's a good point, and I'll visit with Joan. That's an excellent point.
Yeah, but I'm just saying, take a look at the filing you're going to have to do.
No, that's an excellent point.
And I think you're going to find, in my experience, is you're looking at about a 6-week turnaround from those people. And that they're good people, but that's going to be an issue.
Okay. No, I got you that make sure that whoever the Delphi experts are, that they're cognizant of considering the values to different people, not upper middle class professors throughout the world. That's a very good point. Any other thoughts, questions?
Thanks.
Thanks a lot. I leave now? Is that the way it is?
No, it's,
I guess, did we
what
just?
do we do now?
No, this is just his proposal, so you guys sign off and say he's ready, you are.
Oh, yeah. Well,
We have to sign something, right?
Yes.
Second.